I will get started. Welcome to Wu University. Tonight's presentation is IPL Illuminated, Exploring the Mechanisms of Intense Pulse Light for Dry Eye, and I'm joined by Dr. Cory Lappin. I'm your host, Dr. Jennifer Stewart. It's my great pleasure to introduce Dr. Cory Lappin. He received his Doctor of Optometry degree from the Ohio State University College of Optometry, where he concurrently earned his Master of Science degree in Vision Science and served as class president. He then continued his training by completing a residency in ocular disease at the renowned Cincinnati Eye Institute in Cincinnati, Ohio. He practices at Phoenix Eye Care and the Dry Eye Center of Arizona in Phoenix, Arizona, where he treats a wide variety of ocular diseases with a particular interest in dry eye and ocular surface disease. He's a fellow of the American Academy of Optometry, a member of the American Optometric Association, and serves on the board of directors for the Arizona Optometric Association. He's also a member of the editorial board for the online eye care publication, Eyes on Eye Care. He received the American Academy of Optometry Foundation Practice Excellence Award and was named the 2023 Young Optometrist of the Year by the Arizona Optometric Association. So welcome, Dr. Lappin.
Thank you.
I will turn it over to you now, and I will see you at the end with lots of questions.
All right, thank you. All right, everyone, thank you for being here with me tonight for your Friday. I'm really excited to be giving this lecture. IPL is an area of intense interest for many people. Probably one of the areas I receive the most questions about in general, just when it comes to having a dry eye clinic. And one of the things that's so interesting about IPL is that we've had numerous advancements in dry eye and ocular surface disease treatments over the years, but very few have I felt like has been as transformative as we've seen with IPL. But at the same time, IPL is probably one of the maybe least understood of these treatments. And so I really want to kind of just start this lecture off today about talking about what exactly IPL is. So first of all, IPL is not a laser. That's one thing a lot of people are confused about. Is this a laser? Is this not? But it's a non-laser, high-intensity polychromatic light source, and it's produced by a xenon flash lamp. And typically, it's going to produce wavelengths of between 400 to 1200 nanometers in length, and it does so by producing these controlled pulses of intense light, normally with a few milliseconds of duration. So just to give a little bit of history about IPL as well, is IPL has been used for decades, primarily in dermatology and aesthetics. And it would be used to treat skin conditions like hemangiomas, telangiectatic vessels. Most commonly, it's been used to actually treat rosacea. That's one of the most common uses by far. And then in the aesthetic side of things, it's been used for hair removal. And it's a really common thing with photofacials. That's where many of our patients will be familiar with this as far as the cosmetic side of things. Now, when it comes to IPL for dry eye, it was actually discovered by accident. So Rolando Toyos was doing aesthetic procedures about 20 years ago and also treating rosacea. And afterwards, when he was doing rosacea treatments, patients were telling him that their eyes were feeling better. And he was kind of noticing that he kept getting this feedback. That wasn't the intent of the procedure, but he commonly heard that. So he ended up getting a research grant and looking into it. And they found that it was actually indeed helping with dry eye. And that kind of started the ball rolling with all of the developments that we've seen today, where IPL is used for the treatment of dry eye. Now, why does it matter that we know how IPL actually works? And the reason why I think it's so important is the whole concept of a black box. So if you've ever heard this term before, a black box is basically any device that has a certain endpoint. It does something, but how it does it is unknown. It's kind of a mystery how it works. And for many people, for a long time, that's what IPL was. But at this point, we've got a really good idea of the mechanisms behind it and how it's working. So we really want to move beyond this being a black box for multiple reasons. And it's really important to know this because, one, if we know how it works, we're going to have better patient education. We're going to be able to better answer our patients' questions about IPL. It's also critical for determining potential candidates. Who's going to be a good fit for IPL treatment and who isn't? But it's also going to let us know where in our dry eye treatment protocol that we're going to want to implement IPL, and also let us know when we're having some trouble or we're not getting the outcomes we want. It's going to help us troubleshoot it as well. So now kind of getting into the nitty gritty of how specifically IPL works. So as I mentioned, IPL is a polychromatic light source. So it's going to be producing multiple wavelengths of light. And basically all light is a form of energy. So when you're going to be doing an IPL treatment, you're going to be delivering energy. And this is going to be both direct and indirect energy. And what happens is when that light energy, for instance, when you put a handpiece against the face, when you're going to be treating wrinkles, things like that. So you put it against the face, you pull the trigger, and there's going to be a bright flash of light. That light is a form of energy, and that light energy is going to be absorbed by pigment or chromophores in target tissues. And that's going to be where the mechanism of IPL fundamentally takes place. Now, the light produced by a typical IPL device when we're treating for dry eye is going to be determined by what are called cutoff filters. So the standard filter for dry eye is a 590 nanometer filter. And because this is a high bandpass filter, what that means is that 590 nanometers and above will be produced. So if you kind of see this visible light spectrum graph here, you're going to have 590 and it's going to produce all the way from the yellow to the orange to the red, and then all the way into the near infrared, which is even outside the visible spectrum. And everything below 500 nanometers is going to be cut off, which is why they call it a cutoff filter. And the light produced is going to also determine the penetration depth and what target tissues we're hitting. So a good way to always kind of remember this is when you have a shorter wavelength, you're going to have a higher energy, but it's not going to penetrate as deeply. And again, that's what you're seeing with this diagram here. You're seeing the really high air energy, like the blues and the green lights, higher energy, but the penetration depth is less. Whereas the longer wavelengths have lower energy, but they penetrate more deeply. And that's what you're seeing with the red and the red and the orange light. And these different lights are going to, again, based on the wavelength, it's going to determine what pigment is hit and what the target tissue is and the downstream effects. So one of the main principles of IPL is the idea of photobiomodulation. And photobiomodulation is where you're going to deliver energy to a target tissue. And this is going to be in the form of light. And this light energy will then stimulate different intracellular biological processes. And this can be even at a gene and a protein level. And this is going to have a lot of different effects, including regenerative and anti-inflammatory processes. So now this is where we're really going to dive into the science here. And this is going to make you kind of go back to your basic science, your physiology. But how photobiomodulation works at a fundamental level is, again, you're going to get this bright flash of light, and this light is energy. This light energy is going to be absorbed by a pigment or chromophore and cytochrome C oxidase, which is an enzyme involved in the electron transport chain. And by basically delivering this energy to this enzyme, it's going to stimulate the electron transport chain, and it's going to increase the amount of ATP production. And ATP is just a form of energy for the cells. So as you increase ATP production, you're going to get increased function of basically pumps and transporters for calcium. And again, you recall your basic physiology, calcium is a key intracellular signaling molecule. Now, the other hypothesis of photobiomodulation is not only does this enzyme increase ATP by increasing the function of the pumps and transporters, it's also thought that there might be this process called entrainment. And that's where the light energy from IPL causes a physical vibration of the calcium channels, and it changes their permeability. So again, you're going to have a greater increase in intracellular calcium. So now what happens once we have this greater amount of calcium? Well, you're going to have a bunch of different, basically, processes occurring because of this increased signaling. So it's going to affect several key cells, one of which being fibroblasts. So by stimulating fibroblasts, you're going to get an increase in cell proliferation and collagen synthesis. And that's going to play a role in how the skin is affected by IPL. It's also going to affect keratinocytes. So you're going to get increased epithelial wound healing. And then from the inflammatory side, it's also going to change how T cells function, and you're going to get a decreased inflammatory response. And you're also going to upregulate the function of macrophages. So it's going to be clearing away dead cells and debris and pro-inflammatory debris. It also can enhance blood flow, and it's thought to do this by elevating nitric oxide. And this is thought to be either by increasing the activity of nitrate reductase or causing a dissociation of nitric oxide from the COX enzyme during that photoexcitation process of photobiomodulation that we had talked about previously. It's also shown to increase antioxidant levels. And the results of all these processes of photobiomodulation is you're going to get decreased inflammation, and you're going to enhance tissue repair and regeneration. Now, before we kind of go more into IPL, let's just take a look at dry eye more broadly here. So as we all know, dry eye is a multifactorial disease. So that means there are going to be many different contributing factors. I mean, it's incredibly rare, if ever have I seen one dry eye patient who has pure dry eye only due to one cause. So we really want to be able to look at every single element that's contributing to dry eye to fully address their condition. And that's where IPL is such a game changer as form of treatments. Because many of the treatments we use are great, but they target just one part of the puzzle, just one piece of what's causing a patient's dry eye. Whereas IPL is able to address several of the contributory conditions of dry eye in a single treatment modality. So here's just a brief overview of the different benefits of IPL for dry eye, and we're going to go into each of these in more depth as we go on. The big thing is it's going to really improve MGD, and we know that MGD is a major contributor to dry eye. So it's going to improve meibomian gland structure, its function, also the quality of meibum, and it's going to increase tear breakup time. From an inflammatory perspective, it's going to reduce the inflammatory factors found in the tear film and on the ocular surface. And then, again, think back to rosacea. That was one of the primary uses for IPL. It's going to cause destruction of those pro-inflammatory telangiectatic vessels, and that's going to bring down inflammation itself. It also can decrease Demodex and bacterial populations on the lids and lashes, so it's going to help with the blepharitis component. And the other thing is it may also improve blinking mechanics, because as we age especially, we're going to lose that skin tone to our lids, and we all see this in the form of lid laxity. And our blinking mechanics are intrinsically tied to meibum secretion protection of the ocular surface. So if we can potentially increase collagen synthesis with IPL and kind of tighten that lid skin, we might be able to also get better blinking mechanics. So how exactly do we achieve all of these benefits that I just mentioned? And there have been several proposed mechanisms that are occurring all at once involving some of the basic science that I've just mentioned. So first, let's take a look at inflammation. So when we see inflammation for dry eye and the ocular surface, we're going to see the classic SBK, the unstable tear film. We're going to see this very commonly in our patients who have things like Sjogren's syndrome and pro-inflammatory autoimmune conditions. And we know that in dry eye that inflammatory factors are elevated in the tear film of these patients. So how is IPL going to help address this inflammation? Well, pretty much what I just talked about with photobiomodulation. It's going to basically reduce inflammation directly by acting on the inflammatory factors. It's going to improve MGD, so it's going to block any of that downstream inflammation that comes from lipid layer instability that leads to early tear evaporation. It's going to destroy the pro-inflammatory blood vessels associated typically with ocular rosacea. And it's going to decrease the microbial population, so you're going to get less of those lipases and those biofilms that are pro-inflammatory. Now, when we look at some specific inflammatory factors here as well, you're going to get an increase in IL-10, which is a anti-inflammatory factor because it's going to decrease cytokine production by T cells. And then you're going to have pro-inflammatory factors like IL-6, TNF-alpha, and MMPs, all of which are downregulated. Interestingly, IPL has a biphasic effect on TGF-beta. So TGF-beta can both be pro-inflammatory and anti-inflammatory, and it's going to regulate T cell production, proliferation. So what they've actually found is that when IPL is delivered with low energy levels, it's going to decrease TGF-beta, whereas at higher levels, it's going to increase TGF-beta. Then as far as reactive oxygen species, we all know that free radicals are damaging to the ocular surface and just create oxidative stress in general. And reactive oxygen species are actually reduced by IPL. Now, again, going back to some of our understanding of basic science, this is actually very interesting because we know one of the byproducts of the electron transport chain is an increase in free radicals. So we would actually expect that to be increased if we did IPL. However, we actually see that it decreases. So how can this be? And it's actually thought to function what's called an Arndt-Schultz curve response. So again, this goes back to at low energy levels, you might get an increase in ROS formation, whereas at high energy levels, it may decrease it. And both may be beneficial because it's actually been thought that higher levels of free radicals might actually help to kill off bacteria and things like that that can cause inflammation. So MGD, one of the most common factors that we see in all of dry eye, and it's caused by a myriad of things: lifestyle, our blinking behaviors, which are altered by looking at our screens, phones, things like that. Our blinking mechanics from lid laxity, as I mentioned. You can have blepharitis, Demodex, bacterial blepharitis, ocular rosacea. All these things can cause MGD. And it's going to lead to that really kind of thickened, inspissated glands that we see. You're going to get poor meibum quality. And that's going to basically end up with tear film instability, the reduced T-but that we all see. So again, what does IPL do to MGD? Well, one thing it's thought to do is it's thought to liquefy stagnant meibum. However, this is likely not a thermal change. And I'll talk about this a bit later, as it's not actually thought to be melting the meibum per se in the traditional sense, but it might be actually altering the bonds photochemically. Additionally, the meibomian glands are holocrine glands. If you remember this, again, going back to some of our basic science, holocrine glands mean the entire cell is secreted. So meibocytes are the cells of the meibomian glands. And the meibocyte eventually degrades and that becomes the meibum. So through photobiomodulation, if we increase proliferation of meibocytes, we can also increase meibum production. It's also shown that IPL can improve gland structure at a macrostructure level by decreasing gland dropout, and at a microstructure level by increasing acinar cell activity, again, going back to those meibocytes. And it might also improve blinking mechanics, as I was talking, by increasing collagen, because every time that we blink fully with good lid posture, that's going to encourage proper meibum secretion. And this is going to be achieved, again, by IPL helping increase collagen synthesis, which is going to improve the lid rigidity and elasticity. Ocular rosacea. Patients with ocular rosacea are amazing candidates for IPL, again, because as you can see in this photo, you have these fine pro-inflammatory telangiectatic vessels. And these are going to cause all types of inflammation. They're perpetually dilated. And if this is left unchecked, this can cause lid margin notching and scarring. And these patients also have a high correlation with Demodex mites. So you're going to often see these be comorbid conditions. And again, this can lead to inflammation in the meibomian glands, which can lead to MGD. So the way that IPL specifically helps with ocular rosacea is when you're going to pull the trigger, you're going to get the bright flash of light. That light energy is going to be absorbed by the hemoglobin in blood vessels. And this is going to raise the temperature of these fine blood vessels to a point where the blood coagulates and the vessels involute. So basically, you're going to help destroy and cut off the blood vessel. So you're going to get less of that leakage of pro-inflammatory factors. So this is going to help with the cosmetic appearance because the lids and the eyes are going to be less red, but you're also going to get less inflammation because, again, these vessels are no longer leaking these pro-inflammatory factors. Bacterial blepharitis. So classically, we see this with kind of this foamy tear film, this saponification like we see in this photo, which is caused by enzymes that are secreted by the bacteria. And this is going to cause all types of inflammation. Again, it's going to cause scarring of the lid margin, can lead to MGD as it alters the lipid layer, because it's going to change the melting point of meibum. And again, all these things just all feed into one another. But with IPL, it's been shown again that IPL can bring down the bacterial burden on the lids. So you're going to really kind of help decrease the inflammation and all the basically harmful properties of having this overgrowth of bacteria on the lids. And again, if our patients have this lid margin notching, it can help potentially help improve the scarring by increasing collagen synthesis. And I've actually had a patient who came in and one of her primary complaints was the type of notch you see on the lid. And actually, after a series of IPL, she had significant improvement in the scarring. Demodex blepharitis. Another very common condition we see, and it's basically the classic sign are these telltale collarettes that you can see in this photo right here. And again, they're going to cause most of the same problems that we're going to see with blepharitis. You're going to get itching of the lid margin. You're going to get inflammation of the lids and you're going to even get lash loss. And it's just going to basically cause a lot of ocular surface issues. IPL is able to address this because when that light energy is absorbed by a chromophore and the exoskeleton of the mites, you're going to get that same rise in temperature that you got with blood vessels. And the mites are actually going to heat to a point where it causes coagulative necrosis, and it's going to be able to kill the Demodex. And again, that's going to help improve lid margin health. It's going to help with things like MGD and potentially overall better ocular surface health. Mechanical eyelid issues. This is maybe one of the most overlooked elements of dry eye. Again, as I mentioned, as we get older, you get this lid laxity, and you can see this really well in this image. You can see how you have a little bit of inferior scleral show, and the lower lid is just kind of sagging down. Instead of having that nice tone to it, was going to be up against the globe. And you can also get this from lag ophthalmos, very common after blepharoplasty. You can get a poor lid seal, which is where the lids come together, but they don't seal all the way, so you get these micro lid gaps. The other thing is floppy eyelid syndrome, common with sleep apnea. When you pull up on the lid, it just easily lifts off the patient's lid, and that can create a lot of friction by actually physically rubbing. And this can all lead to exposure. You can get this inferior scleral show like I talked about, and this is where you see that classic interpalpebral and inferior band of SBK. And we might be able to help this with IPL because it's going to, again, improve that lid elasticity and that rigidity. So by increasing that lid tone, it can help with the blink mechanics. So we're going to get better meibum secretion. We're going to get better protection of the globe. And it's also going to improve cosmetics. You're going to have a tighter appearance to the lid skin. And like I had mentioned earlier, too, it's going to help improve lid margin scarring. Chalasia. This is another area that IPL has become a very popular treatment for. And chalasia, as we all know, are basically caused by a clogged meibomian gland, and it leads to this chronic granulomatous inflammation. Common with MGD, and it's going to destroy the meibomian gland too, because it's basically going to expand, it's going to cause inflammation. And obviously, we don't want the loss of these glands because that's going to lead to base MGD. You're going to get more gland loss, which is going to lead to tear film instability. Demodex have also been shown to be a common cause of chalasia, and that's because one of the subspecies of Demodex, Demodex brevis, actually burrows and exists inside the meibomian glands, and they can cause this chronic obstruction, which can lead to chalasia. IPL, when used to treat chalasia, however, can use this light energy to help break apart that pro-inflammatory mass. And this is a great option for our patients because it's medication-free and surgery-free. Many of our patients would prefer not to go in for incision and curettage, one, because people don't want to have their lids cut into, but it also, if you've ever seen it done, it's a very relatively brutal looking procedure. And there's nothing delicate about it. You just cut into it, you spin it around, and you try to scoop all of the junk out. Whereas when you do IPL, it's non-invasive and it's able to potentially spare any collateral damage to other adjacent meibomian glands. So let's talk a little bit about actually performing IPL. So one key point I want to mention here before we dive into everything else here is one common mistake I see when people are doing IPL is doing it in isolation. And what I mean by that is they plan on just doing IPL alone without any supportive treatments. And oftentimes this is going to lead to less than optimal results. And again, this goes back to the fact that dry eye is multifactorial. So even though this IPL is great at addressing several of the elements, there is no one treatment that I would expect to take care of everything. So really to maximize the benefits of IPL, you're going to want patients to also be on foundational therapies. And I also say that every patient should have a full dry eye examination and ideally a complete comprehensive exam so you get a better idea of what's going on with their complete ocular health prior to doing IPL treatment. So here's just a summary of base foundational treatments that I use with all of my patients, regardless if I'm doing IPL or not. One is omega-3 fatty acid supplementation. Warm compresses, if it's helpful for patients, some patients really like these, some don't get to them as much. It's more of a comfort thing. It doesn't really do a whole lot therapeutically. It can help melt some of the meibum, maybe at the terminal ends of the ducts, but it's not going to basically generate the type of heat we need to fully melt meibum. Blink exercises can be helpful to kind of basically help encourage proper meibum secretion. Lid hygiene in some form, whether it be hypochlorous acid, tree oil, or an ochre-based cleanser can be good. Artificial tears, though they're mainly used just for comfort, I normally recommend patients having these just to give them the quick relief when they need it. And then for patients who need immunomodulators to help with long-term inflammation, things like Xiidra, Restasis, and Vavai can be helpful. And then we also have neurostimulatory agents, which can help with tear production. That's things like Tyrvaya and the iTear 100 device. And now we even have tear film stabilizers, which can help improve basically the lipid layer by helping inhibit early evaporation. And we have Meibo to help with that. And then for our patients who have nocturnal exposure lag ophthalmos, gels and ointments or moisture chamber goggles can help protect the eyes while they sleep. And then there can also be at-home lid margin debridement treatments such as new lids. So IPL is technically staged by the DEUCE 2 report as a second stage management option. However, I often even offer it to patients early on because it has so many benefits. And many of our patients are looking for quick resolution. And while it's going to take time regardless of what treatments you do for dry eye, some people really want to hit things hard. So even though it's very helpful for cases of dry eye that, have not been so far responsive to foundational treatments, but for even people who want to start at the basics but want to hit it really hard, I always offer IPL even at an initial evaluation for my dry eye patients. And many are actually interested in doing so. So who's a good candidate for IPL? And like I just said, even mild to severe dry patients are going to respond very well. Patients with MGD, rosacea patients, blepharitis, mechanical lid issues, styes, hordeola, chalazia, those who have failed on previous treatments, those who are sensitive to ocular surface medications. So these are the patients who will tell you, even if they put in an artificial tear, it irritates their eyes. IPL is great because it's a drop-free option, so there's nothing that has to be put on the eyes. Also, it's kind of a lifestyle thing. It's more convenient. People who want to avoid additional drops or drops in general. So some patients are like, I'd rather have IPL treatments done periodically than have to use a drop twice a day for the rest of my life. Glaucoma patients who are already putting in multiple drops a day, and the last thing they want to do is putting in other drops. Some of our older patients who have dexterity issues, they struggle to put in drops. IPL can be a great option for them. And then patients who are Fitzpatrick skin types 1 through 4, which I'll talk about a bit more, are good candidates for IPL. So on the flip side, who's not a good candidate? So that would be our patients who are a Fitzpatrick type 5 or 6, patients who have an active herpetic lesion in the area that we're treating, those who have recent surgery, those who are actively undergoing radiation treatments of the head and neck area, and patients with photosensitive epilepsy. Now, there are also some who are more of a relative contraindication. And drugs that cause photosensitivity, doxycycline, tetracycline, St. John's wort, traditionally are avoided for this. Now, the reason why I sell this as a relative contraindication is because, especially with things like doxycycline, this photosensitive response is only thought to be due to UV light. And if you recall, the wavelengths produced by IPL do not involve UV light. Therefore, this is more of a relative contraindication. I have treated patients who are actively using doxycycline with IPL, and they have done okay. Now, granted, most of these ones who are on doxycycline are on lower doses, oftentimes 50 or 20 milligrams. So again, you've got that lower response, so probably less likely to have this response. Herpetic skin lesions, they have been shown to actually reactivate when doing IPL. Again, this is a rare occurrence. However, if someone does have a history of herpetic skin lesions, especially recurrent ones, before performing IPLs, you might want to start them on a prophylactic course of oral antivirals just to have that covered. Melasma, that's what you see in this picture here. These are these dark splotches on the face. Now, the interesting thing with IPL is you can see reports in the literature of it causing melasma to darken, but you can also see IPL being used as a treatment for it. So I always tell patients that there is a possibility if we treat this, that this can cause the lesions to darken. I will avoid them if possible, but this is a discussion to have with your patients before. Some might find that they want to have it. It's worth it, the risk, but definitely talk to your patients ahead of time about this. And it's a similar thing with patients with lupus who have that malar rash. You want to have this discussion before. So other points of note, if you have a patient who has tattooed eyeliner, like you see in this image, you definitely want to avoid that because tattoos have heavy amounts of pigment. So it's going to be absorbed by the light energy of IPL, which can cause burning, irritation, things like that. Again, avoid any facial hair because this can be used for hair removal. Scarring, IPL can actually improve scarring, but just be aware that it's denser tissue. So if you treat over an area of scarring, it might be a little bit less comfortable. And sometimes you might get a bit more of a reaction to that area. It might become red and raised. Facial piercings, make sure that patients take out any nose piercings before you do treatment. And patients with Botox, I typically like patients to wait about 2 weeks before performing IPL if they've had Botox. So IPL, the first thing you do before you perform it is you need to determine the patient's Fitzpatrick skin type. And this basically skin type scale is based on the patient's reaction to sunlight, AKA their ability to tan versus burn. And it's on a scale from 1 to 6. And you can see here, it kind of just goes off of skin tone. So when you're determining a Fitzpatrick score, you give them this survey, and it's basically going to ask them a series of questions. And based on their score, it will give you their Fitzpatrick skin type. However, this might not reflect their true skin type. For instance, you might have a patient who is a Fitzpatrick 2, which is relatively pale, but they live in a warm, sunny environment, like where I'm at in Phoenix. So they're outside all the time, and they've developed a tan, and they're actually closer to a 3. So you can double check this by just visually inspecting the patient. And they also have these sensors like you can see in this picture where you can double check Fitzpatrick type with that. And like I said, this is dynamic. It can change over time. They might be darker in the summer, but more fair in the winter, depending on their sunlight exposure. And if a patient tends to straddle between the two types, what I recommend doing is choose the higher skin type or lower the energy fluence. And then I also recommend with patients with a higher Fitzpatrick score, doing a test shot, which again, I'll talk about more, later on to make sure that the skin doesn't act in an adverse way with the IPL treatment. So after you determine what their Fitzpatrick skin type is, you're going to look at the energy fluence used. And fluence is the energy applied over a given area. And the way to kind of think about this is fluence is going to be, in general, the inverse of Fitzpatrick type. So if a patient has a higher Fitzpatrick type, then you're going to use a lower energy fluence. And this comes back to the fact that with IPL, light energy is absorbed by pigment. So a patient who has a darker skin type is going to have more melanin. They're going to have more pigment in their skin. So they're going to absorb more energy. So you have to use a lower energy because you're going to get more efficient absorption of the energy. Whereas a patient with very fair skin doesn't have as much pigment. They're not going to absorb as much energy. So you can use a higher energy fluence on these patients. Now, this is a very critical step, is determining fluence, because if you look across the literature, most adverse effects involve using too high of an energy fluence. Now, your standard IPL treatment pattern is going to go tragus to tragus over the nose and below the orbital rim, like you can see in this image, typically with about 10% overlap between shots. And these are the supplies you're going to use. You're going to use an ultrasound coupling gel. Now, you want it to be transparent because any light, if you use like a blue gel, for instance, there's going to be pigment in that might actually interfere with light delivery because it's also going to absorb some of that light energy. You want it to be fragrance-free and dye-free in general too, so patients don't have an allergic reaction to it. Patients need to wear some form of eye protection, whether it's adhesive eye patches, opaque goggles, or laser-grade corneal shields. They have to be protected in some way. And then the person performing the procedure needs to wear photoprotective eyewear to protect themselves. So here's this overview of the step-by-step process of performing IPL. So first thing you're going to do is you're going to determine their Fitzpatrick score. Typically, patients 1 to 4 are going to be ideal candidates. Patients at a Fitzpatrick of 5 can be treated, but with caution. I've treated several patients with these. However, I don't recommend it until you've kind of got a comfortable level with it, because you definitely have to approach these with caution and take a very deliberate, careful approach. So once you have the Fitzpatrick skin type, that's going to help you set the fluence, the energy level. Then once you have all those things set, you're going to put that in your IPL device. Then you're going to put on the adhesive eye patches or whatever form of eye protection you're going to do. You're going to put the gel over the area where you're going to treat. Then you're going to put on the photoprotective eyewear yourself. And then you're going to apply the shots over the tragus to tragus area, over the nose, under the orbital rim, and you're going to do 2 passes. And after you do that, go ahead and remove the gel, take off their eye production, and always give the patient sunscreen. Because one of the things is they're going to be more sensitive to UV light after the treatment. So you have to tell patients they have to be very diligent about wearing sunscreen. Additionally, you're going to tell them to avoid any abrasive facial scrubs or any retinol-containing products for at least 2 weeks after treatment. Now, a standard treatment series consists of 4 total treatments spaced about 2 to 4 weeks apart. This is considered the standard, and I really recommend when you perform IPL, you want to do the minimum of 4. Because in my experience, a lot of times when you do 1 to 2 treatments, the patient can't even tell you've done anything because the effects of IPL are cumulative. So you really want them to know that you need the full total of treatments to really experience the optimal effects of an IPL treatment. So that was a very broad overview of performing IPL. Now I'm going to talk about some specific protocols and 3 of the most commonly used protocols for IPL treatment. So the first is the Toyos protocol, and this was the first time that was developed, and it's kind of considered the standard approach. Then there's the Epstein protocol, and this one is predicated on the use of using a greater number of shots at lower energy levels to basically deliver greater cumulative energy, which is more comfortable for the patient. And then there's the Perelman protocol, and this basically also involves aesthetic components as well. So the Toyos protocol, this involves putting on the eye patches, applying the gel in that classic tragus to tragus pattern, and then you're going to do 10% overlap between shots. And after you're done with those two passes, you're going to perform manual gland expression. You're going to put in 1 drop of anesthetic each eye prior. You're going to perform the expression. Then afterwards, you'll give them 1 drop of a topical steroid or NSAID just to help with comfort. And again, the same process is repeated 4 times over a 2 to 4 week period between each treatment. The Epstein protocol. So this was developed by Dr. Arthur Epstein. And this basically came about in our clinic starting all the way about 4 years ago when we really first started doing IPL. And at that time, between the 2 of us, we were doing about 50 IPL procedures a week. And out of us both kind of talking and doing these procedures, this protocol developed. And what we would use is a 590 filter. We place the eye patches on. Again, we would use that same kind of treatment area, but oftentimes we go down just a little bit lower, and we often also treat the forehead as well, especially for male patients because they have a little bit less surface area to treat because of facial hair. And then we would typically wouldn't treat the eyelids unless patients had significant lid telangiectasia. And then this involves what we would do is the same 2 passes. However, we would do about 50% overlap between shots. So this is going to lead to a much higher number of total pulses delivered. So to account for this, we're going to decrease the energy fluence. And this is still, though, going to allow for greater energy delivery cumulatively. So if you do a higher energy level, a patient might only be able to tolerate 30 to 40 shots, where it's not unusual for me to deliver about 100 or more total shots at this lower energy fluence. And we find that patients tolerate this really well, and it's also been very effective. Afterwards, again, the eye patches are removed. We also do not perform gland expression after this, because we have found that this is almost more of a cold expression because, as I'm going to talk about later, you're not really generating a whole lot of heat. So you're not really going to melt the meibum in a classic sense. So what we would typically do is recommend also doing a dedicated thermal pulsation procedure, something like a LipiFlow, tear care, or iLux in conjunction, because you're going to get more of a synergistic effect. And again, this is repeated every 2 to 4 weeks between treatments for 4 total treatments. Now, when we do an on-lid treatment, for this, what you're going to do is you're going to instill anesthetic, and then you're going to put a laser-grade corneal shield to more directly protect the eyes. Then gel is, again, made tragus to tragus, standard pattern, but you're also going to put gel onto the eyelids itself, and you're going to stay you want to keep about 2 millimeters away from the lash line because you don't want to take out any of the eyelashes in the process of treatment. Again, 50% overlap of shots across the tragus to tragus, 2 passes. And then I'll also do 2 passes on the upper and the lower eyelids each. This is typically about 3 to 4 shots. And for this, I use an Optilight device for IPL. So I switch to the smaller handpiece, which is a little bit more nimble, allows me more easily to treat the eyelids directly. Afterwards, I remove all the gel. I remove the corneal shields. Again, I don't perform gland expression after this, but you'll want to do a quick pass over the corneas to make sure in the process of putting on the shields that the cornea didn't get any small abrasions, anything like that. The Perelman protocol. This is another very commonly performed procedure. And for the Perelman protocol, there are 4 basic steps to it. The first is a rosacea treatment. Then it's the classic Toyos protocol, eyelid treatment, and then it's followed by an aesthetic cleanup. So first, this involves putting in the laser grade corneal shields, and gel is applied to the entire face for this. Again, on the eyelashes, on the lids, you're avoiding about 2 millimeters from the lash line. So first part of the treatment is the rosacea treatment. So using a rosacea filter, 1 pass over the entire face is performed. After this, 1 pass, again using the rosacea filter, is used over that tragus to tragus pattern. About 10% between overlap of shots with this. Then after this, the filter is changed out to that 590 filter, which is more of the classic IPL for dry eye filter. And then you're going to do the 2 standard tragus to tragus passes, again with about 10% overlap. And then after this, eyelids will be treated. Again, about 3 shots applied to the upper and the lower lids, each with 2 passes. And then after this, there's an aesthetic cleanup, where an aesthetic specific filter is used. So if patients have any specific areas of angiomas, focal telangiectasia, or hyperpigmentation or unwanted facial hair, these vascular filters and aesthetic filters can be used for these spot treatments. And then afterwards, corneal shields are removed. And again, same pattern we see, 4 total treatments spaced about 2 to 4 weeks apart. So another very common area I'm asked about treatment is, what do you do for chalazion treatment? So this is actually almost exactly the same as an on-lid treatment. You're going to be putting the corneal shields in place. I still like to do the basic MGD tragus to tragus pass because you want to treat those meibomian glands because they're kind of the root cause of a chalazion development. So I'll still do the standard 2 to 2 passes. And then afterwards, switch to the smaller handpiece. And I'll treat on the lids 3 to 4 shots. The difference here is then I'll do an additional 3 to 4 shots directly onto the lesion. And in my experience doing this, it takes normally about 2 to 4 total treatments to get resolution. That being said, I've had more stubborn treatments where it's taken me as many as 7 treatments to get resolution. But this has been working incredibly well. Patients respond well to it. They like not having a non-invasive option. So this is the treatment pattern I typically use for chalazia. Side effects. So side effects of IPL are usually mild and transient. Typically, they resolve within 24 to 48 hours. The most common thing that I see is redness, and it's almost like a sunburn. However, it is not a true sunburn. And the reason why I like to emphasize this is because sunburns are caused by UV light. And IPL does not produce UV light. The redness you're going to get is a little bit of the heat generated for this. And again, this normally resolves within 24 hours. And you might get some edema and blistering, but it's incredibly rare. When you're using the 590 filter, which is relatively gentle, I have not ever experienced any edema or blistering. However, you need to talk to your patients about these because it is possible. The big thing you need to talk about is potential depigmentation, hyperpigmentation of skin, which can be permanent, especially on patients who have darker complexions. Aftercare. Afterwards, and I mentioned this earlier, make sure patients are very diligent about using sun protection. No tanning. They're going to be more photosensitive. And then UV light is also damaging, whereas IPL light is regenerative. So make sure that you really emphasize that, you want to be protected in the sun. In fact, all my patients, before they leave, I have them apply sunscreen directly to make sure that they're covered. Again, avoid retinol-containing products and abrasive facial scrubs. And if they do find that they have some tightness to the skin afterwards, they can use a gentle moisturizer, something like Aquaphor. So frequency and follow-up of treatments. As I mentioned, 4 total treatments is what I recommend. Spaced typically 3 to 4 weeks apart is what I do, but they can be as early as 2 and as late as 5. Some patients fall outside of the bell curve and they do require a 5th treatment. Most will require the 4th, but I will tell patients sometimes if we get to that 4th treatment and they still haven't seen the response we want, I'll typically add that 5th one because, again, everybody's body is different. They respond a little bit differently, and it's not uncommon that they're going to need that 5th treatment. After they've done their final treatment in the series, I like to wait about 4 to 6 weeks after, and then I like to see them back. And that's where I like to repeat any dry eye testing I've done, especially in objective measures, so I can compare where they were before and after, and that will let me know what I'm going to do next. Maintenance treatments. I tell every patient who has IPL at some point, they will eventually have to have a maintenance treatment. Typically, this is 6 to 12 months after their series of 4. And a lot of times, though, they don't need a full series of 4 after this. It's only 1 or 2 treatments are needed, but this can be completely individualized. And when I started doing this with Dr. Epstein, we weren't necessarily sure how frequently most patients would receive a maintenance treatment or need this. But now that I've done this for several years, I can tell you it's just going to depend on the patient. And they'll really kind of tell you. So what I typically tell a patient is after you're done with the treatment, if you respond well to it, let's say you're going around, you're at month 4 afterwards, everything is fine. Then you get to month 5, you're doing okay. But at month 6, you're starting to notice that your symptoms aren't feeling as good, even though you're doing the same treatments you have been doing. This is typically going to be a sign that it's time for a maintenance treatment. And that's why I say, just let me know, and that's when we'll schedule it. I have the full gamut of patients for this. I have some patients who have very severe dry eye. For instance, my patients who have a chemotherapy, which can completely wipe out the meibomian glands, who they do IPL treatments every single month because that's what keeps them feeling good. I have other patients who like to do it every single month just because they find that it keeps all outside treatments to a minimum. And to them, it's worth it to come in once a month just to have their eyes feeling good with minimal work outside of that. Then I also have patients who do 1 treatment every 3 months, every 4, every 6, and basically everything in between. So that's really the nice thing about this is you can customize it to the patient's individualized needs. So here are just some general tips in troubleshooting when you're actually performing a procedure. So when you actually put the handpiece against the face, I always kind of say you want it to kind of firmly make contact, kind of rest against the face, but you don't want to actively push or apply too much pressure. And the reason for that is if you push on the face, especially where those fine telangiectatic vessels are, you can blanch the blood vessels. And you want to actually have blood flowing through the blood vessels because as you recall, the light energy is absorbed by the hemoglobin, and that's how you actually increase the temperature within the blood vessels and cause them to coagulate. So you don't really want to blanch the vessels. When you're doing the procedure, if it ever becomes uncomfortable for a patient, typically all you need to do is give a few extra seconds between shots because this is going to let the skin kind of cool down and it'll be much more comfortable. Typically, even 1 to 2 more seconds between shots will be all that's needed to keep it comfortable. However, if they do find that you're at a higher fluence, you can turn it down at any point to make it more comfortable. You can also split fluence energies between passes. For instance, I might have a patient who's a fluence of 11 for the first pass, everything's fine, and then I bump it up to a fluence of 12 on the second pass. Test shots. I had mentioned this earlier. So if you're doing a patient where you're kind of unsure what their Fitzpatrick score is, they're between a 3 or 4, or more importantly, let's say they're between a 4 and a 5, what I recommend doing is applying 1 to 2 shots, typically on the neck, and just waiting 7 days afterwards to see how they respond. If you find that they're fine, there was no adverse reaction, there's no blistering, burning, anything like that, then you can perform the full treatment. But I normally say kind of cut back on the number of shots, keep the fluence at a minimum, And then you can kind of change that accordingly as they go. If they do have an adverse effect, then you just don't recommend doing the treatment at all because you don't want any of that potential burning, scarring, or depigmentation of the skin. If a patient is between two Fitzpatrick scores, always opt for the higher of the two scores and a lower fluence, because this is going to be safer for the patient. And again, once you've kind of assessed their general tolerance, then you're going to be able to adjust these settings. Treating patients who are Fitzpatrick 5. Typically, treatment is done for Fitzpatrick 1 through 4, but as I had mentioned earlier, I have treated patients who are 5. Really, you don't want to do this until you really got a lot of these under your belt and you feel confident in your treatment. And again, you're going to want to approach this with caution. You're going to want to talk to the patients very, very clearly about potential risks. And then you're also going to always do the test shot, let them know, you're going to start being more conservative, but that you're going to be able to adjust things as they go. Again, I've successfully treated patients who are 5, but make sure, you're comfortable and you are very cautious when you approach this. So post-treatment expression, I'll even have patients ask me about this because they've read up on IPL, and oftentimes they'll say that, they've read about meibomian gland expression afterwards. So initially when IPL was first kind of being, investigated for IPL treatment, it was thought that it was helping MGD by actually melting the meibum in the glands. And the reason for this is because IPL obviously generates heat in the process. However, as it's been investigated further, it's actually unlikely that the heat produced by IPL is substantial enough to provide melting. Because as you know, when you're trying to melt the meibum, it's going to be at a certain temperature. You need 42 degrees Celsius roughly, and it needs to be sustained. The heat generated by IPL is too brief to fully melt the meibum. So it's likely that you're not getting a full thermal melting. Now, you might have some liquefaction of the meibum, but this is more of a photochemical process where that light energy is altering the bonds within the meibum. So doing just a base expression afterwards is more akin to doing a cold expression. And we know that with cold expression, one, it's very uncomfortable and it's relatively ineffective. And patients really find that it's not an enjoyable process. And the meibomian glands are so delicate, you don't want to potentially damage them by trying to force out stagnant meibum. So we found that just a better alternative is using a dedicated thermal pulsation procedure or things like RF because they have more of a synergistic effect. So direct on-lid treatment. Typically in our protocol, when I use the Epstein protocol, this is reserved for those who have heavy lid telangiectasia, or again, we're treating chalazia. And you can also do this for patients who have significant mechanical lid issues. If you find patients have excessive lid laxity or lid margin scarring or notching, that might be another time you want to do the on-lid treatment here. And in this photo here, you obviously see a patient with a chalazion, and they have that corneal grade, laser grade corneal shield in place. Now, one potential challenge of treating on the lids is the orbicularis oculi muscle and the tarsal plate. So these are very thick structures, and the tarsal plate, as you know, it's dense collagen. So this is a highly reflective structure. So that might provide, might kind of reflect some of the light energy that we're trying to get to the lids now and the meibomian glands. That being said, what's probably reaching the meibomian glands more easily is near infrared light, because that's not visible light. So it's not going to be affected by that dense collagen, that white reflective tissue, as much as visible light might potentially be affected. Setting expectations for patients. I always tell patients they need to do at least 4 treatments to have maximum effect. And after the first treatment, they're likely not going to tell I even did anything at all. After the second treatment, some patients can tell a difference, but it's typically not until the 3rd or 4th. So if they come to me 2 treatments in and they say they haven't noticed anything, I said, no need to be discouraged. You're still right on track. Fifth treatment is needed for some patients. That's just a reality of things. Like I said, some people are on the bell curve of 4, some people need a few more. That's normal. I always let patients know that ahead of time. And then I also let them know that this isn't one and done. Eventually, they'll need maintenance, typically between 6 to 12 months afterwards, some sooner, some later. Now, I also say in my experience, I see about a 20-80 split with IPL. And what I mean by that is about 80% of my patients after a series of IPL will both feel better and their objective testing measurements will improve. 20% of patients will come to me and they won't necessarily feel much different, but when I look at their objective testing, it's improved. And this is where I let them know that their symptoms are lagging behind the signs, that I'm seeing objective improvement, but we might just need to do another treatment or make some other alterations to their treatment program to get them feeling as good as they're looking. And this again goes back to the fact they still need to be very consistent with their other foundational treatments to maximize the effects of IPL. And then at the end of the day, there's still nothing that's guaranteed. Even though it's incredibly rare for any of my patients to not receive some benefit from IPL, it's going to happen for some patients. That's just the nature of everything. So I don't like to be a downer for patients. I will say that I see great success with my patients, and the vast majority of them, probably, up to 95 or 98% of patients get some benefit. There always will be that 1 to 2% of patients that just don't respond. But I think it's always worth it based on the pure statistical probability that they will get some form of improvement. And again, just looking at some of the discussions with patients, what I recommend doing is, if you have it available, things like meibography, non-invasive tear breakup time, lipid layer interferometry, and blink analysis, those give you great objective data that can show you and demonstrate to both you and the patient the improvement you're getting with IPL. When you talk to patients, listen to their individual issues. That's going to help lead you to what's the best treatment, if IPL is going to be a great option for them. And then after they've kind of talked to you about, do I have nighttime dryness? Do I have itching? Do I have this heavy kind of redness to the lids? This is going to help tell you what their specific issues are. And then you can let them know, now that you know how IPL functions, how IPL can address these specific issues. Because once you explain to them the mechanism of action in a very understandable way, they can get it. I often tell patients that what's going to happen with IPL is it's just a form of light energy. And when that light energy goes into the skin of the face, for instance, when it stimulates collagen production, that's going to be affecting the skin cells. But when that light energy goes to the meibomian gland, it's going to help break apart the clogged oil. It's going to help increase and stimulate the production of new oil. And it's going to help those spidery blood vessels kind of involute and close down, so there's going to be less inflammation. I also like to address as many questions as possible at that visit, mainly because I want to be able to have a good workflow. Typically, what I recommend for practices is staggering all of your IPLs in a single day. I call it my procedure day. I like to do all my IPLs back to back to back, because that just helps with workflow instead of jumping between an examination and an IPL treatment. You also want to try to educate your staff so everyone's on board, so they're getting a consistent message for patients, both from you, the doctor, and from the staff. And at the end of the day, when it comes to discussing finances for this, it's an out-of-pocket cost. So what I like to do is I say, never sell an IPL treatment. I like to just discuss all of their options. I let them know why IPL is a great choice. And if it's something they want to pursue, it's a great option for them. But at the end of the day, it's up to them if they want to pursue it. It's just my job to educate them on their condition and offer the best treatment options available. So just as a summary, IPL, it's going to help in multiple different mechanisms at once. It's going to help improve MGD by improving gland structure, the function of the meibomian glands, the quality of the meibum, and the tear breakup time. And it's going to do this through photobiomodulation and improving contributory conditions like ocular rosacea and blepharitis. It's going to reduce inflammatory factors in the tear film and on the ocular surface. It's going to destroy those spidery vessels that are associated with ocular rosacea that cause inflammation. And it's going to decrease the microbial burden on the lids and the lashes as well. And then it might also improve blinking mechanics by increasing collagen synthesis. And it's a great medication and surgery-free alternative for treating lid lesions like chalasia. And it's going to improve cosmetic appearance. It's going to decrease erythema, and it's going to provide a tighter appearance to the skin. So here are all my references for anyone who is interested.